Good afternoon, everyone. Thank you for joining us at our Improvement and Innovation Showcase at the Commission on Excellence and Innovation in Health. Think Sepsis, Improving Care and Saving Lives. I'm Heather Barron. I'm the Director of the Clinical Networks Program here at the CEIH, and it's great to have you with us today. I'd like to begin by acknowledging the land that we meet on today. It's the traditional lands of the Kaurna people, the custodians of the Greater Adelaide region. And I'd also like to acknowledge the Whadjuk Noongar people of the Perth region, as we have a guest presenter from WA, and acknowledge any other traditional owners of lands on which you live and work today. We respect their ongoing connection to land, sea and community, and to their cultural beliefs that are still relevant to them today. And as today marks National Closing the Gap Day, we recognise the inequity of health outcomes and life expectancy for Aboriginal people. And for sepsis, hospitalisations occur around twice the expected rate based on population size. That's both nationally and here in South Australia. So this requires concerted effort, a willingness to listen and do things differently to improve outcomes. But I also just want to acknowledge the resilience and strengths of Aboriginal culture, and that sustainable change can be achieved when we engage with Aboriginal leadership and communities. So a couple of housekeeping issues or items. This session has been preset to keep your mics on mute and the video feed turned off. However, this will be enabled during our question and answer time after the presentation. Note that only the presentation will be recorded and published. The recording will be stopped for question time. When we get to question time, please use your mics or chat function to ask your question. And of course, it'd be great if you turn on your camera so we can see you. Finally, after the Q&A, there will be a quick survey for you to complete, literally a few minutes, and we'd really appreciate if you could do that to assist us in evaluating today's event. So for those who are unfamiliar with the Commission on Excellence and Innovation in Health, or the CEIH for short, we're the lead agency for innovation in healthcare in South Australia, and we love to bring consumers, clinicians and other collaborators together to turn ideas into better healthcare, and that's what we're here to do today. And our vision is together creating health and prosperity for all. So what if the big idea was connecting all the small ideas? Well, this is the essence of why we host these showcases, which is helping to connect people in South Australia and across the country, providing a space to explore what others have learned. It's about sharing ideas, improvements and innovation. During our session series, they last for about approximately 40 minutes, and they are available online at any time. We post them on YouTube. We aim to keep it simple and share work that's happening across the sector at any stage or at any level of success. We're not just waiting for work to be published or complete. We focus on work that's in South Australia, but we obviously also showcase things that are happening elsewhere in our country. And if you have a story to tell, if you might have succeeded in solving a problem or whether you've learnt something trying to do it along the way, please get in touch with us via email that's displayed here. We'd love to hear about it, and it might be something you could present in a showcase. So our Improvement and Innovation Showcase Series 18 is about sepsis, and we're going to hear about the current state and future directions of sepsis data in Western Australia today. So why sepsis? In our context, it has been identified by our Health Chief Executives Council, Safety and Quality as a priority issue to be addressed in our health system because of its significant impact on safety, quality, equity and system efficiency. And a few key statistics there are listed for you on that slide. We've begun work to understand the burden of sepsis in South Australia. And as this shows, there are approximately 6,000 separations in public hospitals, although that data is being refined as we're improving our process with that. And although the numbers are relatively small when you compare them with all of the admissions across our system. There's significant issues from mortality rates, long lengths of stay, ICU utilisation, and long-term physical, cognitive and psychological challenges for those who are left following the condition. Our fourth session in the series will be next week, and that will be strengthening sepsis survivorship and best practice care. And we have a presenter, Dr. Jacob Dye, and a consumer, Fiona Gray. So it'd be great if you'd like to join us for that, and there's information there about joining the series. So today we're going to hear from Ben McFadden, who's a senior data scientist with the Western Australia Department of Health, working in the Healthcare Quality Intelligence Unit. He leads several statewide dashboards, including diabetes, renal, general surgery and sepsis, and has supported the development of the WA Sepsis Registry. Ben's research focuses on using machine learning to improve sepsis and bloodstream infection outcomes, particularly blood culture prediction. So warm welcome to you, Ben, and I'll hand over to you now to present to us. Thank you.
Thank you very much. Thank you for the opportunity to present today. So today I will be talking about three main areas. So first, whilst you've probably kind of had an introduction to sepsis over the last few sessions, I'll provide an introduction from my perspective, and in addition to introducing the current state of sepsis data. I'll talk about sepsis data in Western Australia and how we use it at the Department of Health, particularly how we visualize it, and introducing you to the dashboard that we've developed. And then lastly, I will talk about some future aspirational goals for how data can support sepsis care. So sepsis is a complex syndrome characterized by physiological, biological, and biochemical abnormalities resulting from a host response to infection, which can and often leads to multiple organ dysfunction and death. What differentiates sepsis and infection is the dysregulated host response and the presence of organ dysfunction. It is considered the #1 cause of preventable death worldwide, and early identification and timely intervention are essential for improving clinical outcomes and minimizing complications. While sepsis can result from all pathogenic organisms, it is most commonly discussed in the context of bloodstream infections resulting from bacteria or fungi. And you see kind of this graphic here, sort of from the recent sepsis epidemiology report, shows some of the key metrics that were analysed. And you'll see later that in WA, we are able to look at these metrics on an ongoing basis. This particular graphic just further illustrates the interplay between sepsis and infection, and how someone can have an infection without sepsis, and it also illustrates how important it is to capture these patients early so that their condition does not deteriorate. As you may be aware, there are a number of early warning scores for sepsis that have been proposed, trying to identify these patients early, such as Muse, News2, and QSOFA. Additionally, sepsis can come with many long-term health issues, so post-sepsis care is becoming an increasingly important focus area. Beyond its acute phase, post-sepsis syndrome is characterized by long-term immune dysregulation, chronic inflammation, and metabolic dysfunction, predisposing survivors to recurrent infections, cardiovascular disease, and neurocognitive decline. And you can just see here some of those different warning scores. The sort of pre-sepsis state is also an emerging area of interest. Developing robust biomarkers and risk stratification models or strategies is essential to identifying patients at risk before clinical deterioration occurs, as well as antimicrobial resistant sepsis, an ongoing issue with initiatives relating to antimicrobial stewardship at the forefront of preventing this. And there's also other sort of subsets such as culture negative sepsis, as well as neutropenic sepsis are also areas of concern. Again, this particular graphic highlights the importance of being able to identify patients with an infection before they start deteriorating. The treatment and care for a patient with sepsis can often start in the community and extends all the way through their hospital admission to rehabilitation and long-term support after they've been discharged. Achieving positive outcomes depends on the integration and interconnection across multiple stages of care. And the patient journey can often look very different for each cohort of patients. There are a number of sepsis challenges, particularly in the data space. So one of them is, how is sepsis defined? Often we use ICD codes, but there are other ways of identifying sepsis which might sort of broaden the cohort capture. And we need timely and meaningful data as it's critical for improving patient outcomes across the patient journey. Recently, you may have seen the National Sepsis Epidemiology Report, which was produced by the Commission, and key findings particularly revolve around sepsis in admitted care, sepsis recorded as a secondary diagnosis, 30-day post-sepsis readmissions, 30-day pre-sepsis separations, and then several trends over time, such as length of stay or time in the ICU. And again, when I present images from our dashboard, you'll see how we're tracking these trends over time. Similarly, the Commission also compiled the National Sepsis Data Plan, which is a 5-year roadmap designed to transform how sepsis is measured, tracked, and responded to across Australia. And combined with the National Epidemiology Report, it highlights the need for consistent national data to support benchmarking, solution development, and quality improvement. So now I'll go into sepsis data in WA, particularly the Department of Health Healthcare Quality Intelligence Unit. So in our team, everything that we do is grounded in safety and quality principles and practices. And so we look at what are the things that we do well, why does it work well, what are those areas that we can be better at, and acknowledging that just because things were always done a particular way doesn't mean that that is the best way. Why does data matter in the healthcare context? Well, we all know that healthcare is complex and high risk. Variation in care can affect outcomes quite significantly. The assumptions that we make doesn't necessarily mean evidence. And we need ways of making objective measurements. And of course, you can't improve what you don't measure. And the aim is to ensure care is safe, effective, and continuously improving by providing high quality intelligence. So you might be familiar with funnel plots and SPCs. If you're not, I'll give a quick run through now, because this is really the foundation of how we present data in our dashboards. And this is based on the NHS England Making Data Count approach, which you may be familiar with, created and championed by Samantha Riley. This includes the use of statistical process control charts instead of the red, amber, green style of reporting. And you'll see these charts are used extensively in the way that we present sepsis data. And so you can see here is the funnel plot, which is a simple scatter plot that shows the indicator performance by sample size, such as patient volume, and allows us to compare sites against one another. And you can see the control limits there are set to 3 standard deviations from the mean. And this means that generally we would expect 99.7% of hospitals will fall within the control limits, which are the dotted lines. And if values fall above or below these limits, we class them as an outlier. From this, we can infer something other than random chance has changed, and it might be factors such as data quality, differences in case mix between sites, or any other factors, and they warrant investigation. The SPC chart similarly plots the performance of an indicator over time with upper and lower control limits to identify when a process is performing unexpectedly or said to be out of control. And again, the control limits are set to 3 standard deviations from the mean, and we would expect most data to lie within those control limits. The SPC charts that we use have outlier highlighting. So a blue favorable pattern is highlighted, you can see on the left there, and then orange is used to highlight unfavorable patterns. These colors are colorblind friendly, and there's also pattern detection for outliers, for shifts, and as well as trends. And you'll see this in action. So why do we use these tools? Well, red, amber, green style reporting and displaying of data often leads to alert fatigue, demotivation of end consumers, and can hide important trend signals. And so you can see here a lot of red and some green, but this is, and you can see that it doesn't necessarily provide useful information, and it's quite difficult to interpret. So what is a better way of viewing this data? In the first case, you'll see that this is a particular example of general surgery data that is all in the red. And this gives the impression that general surgery is performing poorly. However, viewing this data as an SPC chart shows that whilst the target is not being met, we are actually improving, and we should be celebrating this and encouraging them to continue along this path. In the other case, we can see rheumatology. They have a similar sort of red pattern here, but if we look at the SPC chart, we can see that not only is the target not being met, rheumatology continues to deteriorate. And in this case, we might be able to apply some of the lessons from general surgery to improve outcomes for rheumatology. So our team at the Healthcare Quality Intelligence Unit, or HQIU, has built many of what we call these deep dive dashboards, showing data for a range of areas, including sepsis. And we use this data to monitor safety and quality over time and identify areas for improvement, benchmark performance against other hospitals and identify best practice, engage with clinicians and staff in improvement efforts, and report progress to stakeholders, including boards, clinicians, staff, and patients. As well as we also build tools to support analytics and QI monitoring. So our sepsis dashboard acts as a data asset to support quality improvement and monitoring around sepsis-related separations across the state. And data comes from several sources across the WA health ecosystem. So in WA, we currently don't have an electronic medical record, but we do have a warehouse in which a lot of our systems feed data into, and then we can access that. So for example, we have patient administration systems, which contain data relating to patient episodes such as ICD codes, admission times, and length of stays. We have discharge summary and clinical summaries, which provide us with information such as medications on discharge. We have access to pathology and microbiology. This allows us to plot pathology trends in addition to having access to microbiology data such as blood cultures and antimicrobial resistance information. We have access to the emergency department information systems for elements such as diagnosis at triage or length of stay in the ED. And lastly, we do have a state REDCap audit tool that supports the collection of data points relating to some of the clinical care standards, such as was lactate taken as part of screening, or were patients placed on a sepsis pathway. And all of this data feeds into the sepsis dashboard. So the sepsis dashboard, the data in the dashboard pages for the purposes of this presentation has been modified so it doesn't reflect the true nature of trends and patterns across WA, but I will be focusing on what we present and how we do so. So for example, we present a demographics page, and you can see the number of separations with sepsis and measures such as average age, percentage of those under the age of 19, which have been excluded from this example, the percentage age 65 and over, ATSI status. We also have a number of filters on the side, which support slicing the data to help end users analyze the data more effectively. Separations are included if they were clinically coded with a sepsis ICD code or had sepsis in their discharge summary problem diagnosis. We can also stratify the data based on sepsis type, including sepsis unspecified, sepsis specified, so where we know what the causative pathogen is, maternal sepsis, neonates, and septic shock. The dashboard is actually available to all WA Health employees, so all the employees at different sites in all different areas can see the dashboard. We have a length of stay page, which allows us to view the length of stay measures such as average length of stay and median length of stay. Again, the filters apply across all of the different pages and then therefore can be stratified depending on the user's needs. And you'll see the use of the final plots and SPC charts, which is consistent across all of the different dashboards pages. And also can be changed for health service provider or hospital, but those have been removed for the purposes of this presentation. Similar to what we see in the National Epidemiology Report, we can monitor the rate of ICU admissions, and we also have a separate page which is dedicated to the number of hours in the ICU. We have an unplanned readmissions page, and that allows us to monitor readmission rates for sepsis patients and readmission rates for those discharged against medical advice as well. The number of days to readmission can actually be dynamically modified. You can see there the kind of silver box, and that allows users to actually filter the page for the readmission time that they are interested in. So quite often, clinicians and those analysing the data want to look at 30-day readmission rates, 90-day readmission rates, and then yearly readmission rates, and that allows them to do so. On sort of the back end of this, we can look at what patients are actually readmitted with as well. So this kind of gives us an idea of, for those patients that are discharged after having sepsis, what are their kind of ongoing comorbidities and what are they being readmitted with. And this is important for kind of making cases for sepsis outpatient clinics. We have dedicated comorbidities page, so this gives users the ability to analyze the comorbidities that patients are presenting with. This includes comorbidities from both the Charlson and Elixhauser sets, but the side panel filters can also be changed to look at other comorbidities that aren't necessarily in those two scoring systems. And when users select a particular comorbidity, in this case, you'll see in the Elixhauser comorbidity section, diabetes has been selected. The top right SPC chart will change to show the pattern for patients who have been diagnosed with sepsis, but also have a diabetes comorbidity. We have access to a range of different pathology tests, as I mentioned. So, for example, in this particular page, we can look at trends relating to the collection of blood cultures for patients with sepsis. And in this case, we can see the percentage of separations where a blood culture was taken, and the proportion of those blood cultures resulting in pathogen growth. Like the rest of the pages, this can be broken down by hospital site, and also has different options to filter on separation, but also look at sort of provider stays, hospital stays, or patient stays as well. Similarly, this also applies to the dedicated lactate page. So in this particular case, we're looking at the proportion of separations where lactate was taken. We also have a much wider range of pathology tests that we're looking to integrate into the sepsis dashboard, and also present in many of our other dashboards, things like EGFRs, C-reactive proteins, full blood counts, and we have access to all that data, and we will be looking to bring that into the sepsis dashboard. More recently, modifications have been made to extend the microbiology components of the pathology tests to include other microbiology cultures. So, for example, urine, respiratory, tissue, and wound cultures as well. What we're also looking at is kind of extending this to be able to look at the antimicrobial susceptibility results. So, for example, when a blood culture, when the data that we get access to is kind of like in a report format like this. And so you can see the growth of a particular organism. In this case, it's a Staph aureus bacteria. And what we can do is we can pull out the particular organism. So as in this case, Staph aureus, but what we can also do is pull out the resistance information. So you can see there the antibiotics, what antibiotics were tested, and whether or not they were resistant, or whether that organism was resistant or susceptible to those antibiotics. So this is all present in the free text. And so we can extract that information into a more structured format. And then we plan on presenting this data in the dashboard to show not only the patients with sepsis and those that have a positive blood culture result, but were they also dealing with antimicrobial resistant sepsis. So that will give us a much more granular way of analysing that particular cohort. There are also a number of other pages which I haven't shown here, such as all-cause mortality. We have a particular medications on discharge explorer, so you can see what patients, medications patients are discharged with, particularly what antibiotics they're being given on discharge. We also are able to look at emergency department data, as well as some inpatient trends. There is a dedicated page, as I mentioned, to the particular REDCap sepsis audit tool that we have, but that's kind of restricted to certain users, so it hasn't been presented here. And that captures some of the data points that we aren't able to capture automatically, things like were patients put on the sepsis pathway, or were lactates done as part of screening, and captures a number of other indicators as well. So that's the current state of the sepsis dashboard that we have, and the different types of data that we present to our consumers and stakeholders. So where would we like to go? What are some of the future goals for using this data for sepsis care? So one of the areas I mentioned was cohort identification. And so currently the dashboard includes those patients where there was a sepsis-related ICD code. This is a really good starting point, but there are issues with that particular method. And so we're looking into other ways of potentially broadening that scope and capturing a much larger range of potential sepsis patients. This can be done in a variety of ways. One such way is utilizing the pathology data and clinical data to sort of create these sepsis phenotypes. I'd be interested to know what other jurisdictions are doing to handle this, and most importantly, if the jurisdictions can share their methods for sepsis cohort identification or phenotyping. Part of this kind of future development and improvement is the utilization of unstructured data, so particularly things like text. I showed you the case of the antimicrobial susceptibility data, which is one way that we can utilize the unstructured data that we have access to. But there is such a great wealth of unstructured data that is often available. And this particular data provides an opportunity for more advanced analytical approaches to identifying sepsis cohorts. In particular, the use of large language models for sepsis is kind of a growing area of research. In this particular quote, the authors of this particular paper, they demonstrate the feasibility of using large language models to extract complex data from unstructured clinical text at a scale which is just simply not possible from manual record review. And then that's also something that's come up a lot in our stakeholder engagement, is the need to be able to find ways of supporting the manual review process. So this is actually some data that was taken from that particular paper. And ideally, you would want some type of algorithm to be able to run over the notes and identify sort of key terms that might help to identify patients with sepsis. So in this case, for example, urosepsis, identify different sort of symptoms, potentially look at antibiotics or treatment as well. And that also might assist with antimicrobial stewardship activities. Additionally, I mentioned the area of post-sepsis support, and this is an increasingly important area of focus. We're aware of the burden that sepsis patients have once they are discharged from hospital, and there often isn't the support frameworks there to actually help them recover and rehabilitate in the long term. And so how can we use data to support the creation of post-sepsis support resources? And ultimately, how do we utilize that data in feedback loops to ensure that these supports are actually making a difference for patients? And again, that loops back into sort of the readmissions data in particular. I really like this report that was put out by the Commission regarding the coordination of care and post-sepsis support, and how the different jurisdictions and as a nation as a whole, we can move towards providing better, more coordinated care for patients post discharge. So in some closing remarks, it's always great to see how much work is being done across the country from the different states to use data to ultimately improve sepsis care. Each jurisdiction is doing really great work in the space. And I hope that going forward, ultimately, we can continue to share our learnings between us, our experiences and different resources to continue to improve sepsis care and the quality of improvement. And particularly, how can we work together despite the fact we might have different systems? Some states have electronic medical records, states like Western Australia do not. So how can we share our learnings and how can we better support each other to ultimately realize the vision of utilizing data to improve sepsis care? I have provided a number of references that you can sort of look at the recording. Many of these papers are quite good and they cover the range of areas that I've covered today. And lastly, if you are interested to learn more about our sepsis work, in particular, if you would like to see a much more in-depth look at the dashboard with a live demonstration, then that can be arranged. You can email us at safetyandquality@health right there. We also have, as I mentioned, a number of other dashboards that we'll be happy to share our learnings from. Like I said, cardiovascular, renal, diabetes, general surgery, hospital-acquired complications, quite a large range. So please do reach out to us if you are interested in any of that. We're also very open about sharing things like code and our methods for how we've visualized data. In particular, Andrew Johnson, who's part of our team, has developed the SPC charts and final plots for Power BI specifically. And amazingly, they're also freely available. So if you need any assistance with setting them up, if you don't currently use them, please do feel free to reach out. We also do have a GitHub repository, which does have some additional resources for some of our work. So thank you again for the opportunity to present today. I'm happy to take any questions. I think there is, I'll leave the to take control back. Yep.
Thank you, Ben. Really great presentation and so much work that's been done there to establish all of those dashboards, and really interesting to see how you've put that together.